Yeah, I don't want to start too late because I want to give you guys enough time to talk. Welcome everyone to another session of SWOCCS, or Southwestern Ontario Critical Care Series. It's an initiative started by myself, Eric Walser, and Ian Ball. Now, this is available for Section 1 credits for continuous medical education. And our program is meant to try and improve the collaboration and cooperation between all the critical care centers throughout the region and help with education from all sort of interdisciplinary aspects of critical care. We have two amazing speakers today, both Dr. Tennille Gofton and Dr. Derek Debicki. Dr. Gofton completed her medical school at Dalhousie University and followed her neurology residency training at Western University. She has dual fellowship training in hospice and palliative medicine from Memorial Sloan Kettering, and in neurocritical care and electroencephalography at Western University. Dr. Gofton is currently an associate professor at the SWOCCS School of Medicine and Dentistry in the Department of Clinical Neurological Sciences and has been a faculty member since 2012. She is currently the acting director of the NeuroCritical Care Fellowship Training Program. Dr. Debicki is an assistant professor of neurology in the Department of Clinical Neurological Sciences at the SWOCCS School of Medicine and Dentistry at Western University. He obtained his Bachelor of Sciences in Physiology in 2000, his Master's in Neuroscience in 2002 from Western University, prior to completing Western's concurrent MD PhD program in 2009. Completed his residency in neurology in 2014 and at the Department of Clinical Neurological Sciences at Western University, and had a subspecialty fellowship in neurocritical care and epilepsy under Dr. Gofton and Dr. Bernio. He joined the department in 2015, and we are both very lucky to have these experts talking to us about seizures in community ICU practice. Thank you very much, guys.
You're welcome. We're happy to be here. Should I share slides then? Okay.
Yeah, please go ahead.
Okay. Okay, hopefully that works. So yes, Dr. Gofton and I are really happy to be here. I get a chance to speak with all of our colleagues in the region. We're used to talking about seizures, but a unique kind of aspect of this is talking about seizures outside of the context of an academic center and seeing if we can put some practical thoughts around that as well. So we'll hopefully have the intent is to have a relatively short presentation so that we have lots of time for questions and scenarios that you might have, which will hopefully provide good value for you. So we'll start by speaking about seizures in critical care. Dr. Gofton's disclosures of funding and advisory board member, and the same with myself, but nothing relevant for this talk. So the objectives today are to review seizure definitions and types of seizures. So it wouldn't be a seizure talk without doing that first. To discuss approaches to seizure management in status epilepticus, which Dr. Gofton will go over, and then also to consider seizures in the context of community hospitals. So a definition of seizures, we always start with talking about what is a seizure, and basically this is a group of neurons in the brain that become excessively active and become synchronous in an abnormal way and causes signs or symptoms related to that. The International League Against Epilepsy always does a little bit of an update to define and classify seizures, and the most recent update was in 2017, where we define seizures as either being of focal onset or generalized onset. So that means that seizures can either start in one spot in the brain, and or it can start across the whole brain all at the same time. And particularly with focal onset seizures, we identify them or describe them based on their semiology, or what is the first symptoms that the patient experiences. And that tells us where in the brain. It can help us both lateralize. Do we think it's coming from the left side of the brain or the right side of the brain? But it can help us localize as well as to whether it's coming from the temporal lobe or occipital lobe, and just helps us know kind of upfront what we might be dealing with. So it's important to really understand what are the first symptoms from the patient, It helps us to then understand whether that's a motor onset, so whether there's actual limb movement associated with that, or non-motor onset, which might be some type of an experiential phenomena such as fear, or what we describe as an epigastric rising sensation or a funny sensation coming from the stomach, or it might be behavioral arrest, it might be autonomic features. So whereas generalized onset, probably the vast majority of known generalized onset seizures and generalized onset epilepsy probably starts in the pediatric age group, the majority of them, but that can also include motor or non-motor, non-motor being absence seizures, as you might have kind of heard about. But of course, we can always have focal onset seizures that start in one spot in the brain and then go to the rest of the brain. So that's what we call focal seizures, then evolving to bilateral tonic-clonic seizures. And then sometimes we just don't know the onset. And in fact, if you're dealing with seizures in the hospital and you walk into a patient's room and they're having a bilateral tonic-clonic seizure, you may describe that as generalized, but we might not actually know whether it was focal at onset if nobody witnessed the start of it. In the context of hospital management of seizures, and oftentimes we think about a concept of whether a seizure is provoked or unprovoked. And with provoked seizures, meaning that they're due to something, a proximal cause, they can also be described as acute symptomatic seizures. And really, there's a close temporal relationship between some kind of new acute CNS problem, whether that's metabolic or structural, infectious, that causes seizures. So we might think of something like a posterior reversible encephalopathy syndrome, or PRES, which often is associated with seizures. That could be, an acute symptomatic seizure, or if there's immediate seizures related to traumatic brain injury or stroke. But there's usually something clearly identifiable and something that's causal to it. Again, we might, from a metabolic point of view, might think about hyper or hyponatremia or hyperglycemia. We can have infectious processes or other toxins as well. And in large part, in these kinds of types of seizures, if we're able to kind of help with the underlying cause, and provide supportive care, then that doesn't necessarily portend that there might be more seizures down the road or develop to epilepsy. In terms of causes of acute symptomatic seizures, as you can see, it's quite variable. We can either have cerebrovascular diseases, head trauma, infections, all roughly kind of equal weighting in terms of what might cause it. The other way to think about it is having a patient with a type of an injury in your hospital, and saying, well, what is the likelihood that maybe a patient with this might develop a seizure, and how carefully do I need to watch them? So some things such as moderate to severe DBI or a CNS infection, maybe upwards of a third of patients might end up having some type of seizure associated with that. So you might want to really watch those patients carefully. In terms of prophylactic treatment of seizures, really only moderate to severe TBI remains really the only thing that we would consider using anti-seizure medications in a prophylactic way. But this just kind of gives you an idea of that we can have to deal with symptomatic seizures in the hospital. Again, when we look at seizures in the hospital, then we can kind of break them into other categories, one being convulsive seizures, where we actually see motor manifestations associated with that, or non-convulsive seizures, which Dr. Gofton will talk a little bit more in detail about, where we see just behavioral changes or cognitive changes with that, but not necessarily have the convulsions associated with that. We also distinguish between discrete seizures, which patients might have, and then what we call status epilepticus. And again, status epilepticus may be convulsive or may be non-convulsive in nature. And with that, then I'll hand it over to Dr. Gofton, who will talk a little bit about managing these types of seizures and status epilepticus in the hospital.
Next slide, please. Thanks. Okay, so in hospital, non-convulsive seizures are some of the most common seizures that we run into in critical care specifically, which is difficult because obviously we recognize that not everybody on this session has easy access to an EEG within their institution. So then the question becomes, how can we recognize this or look for it without an EEG? And how can you best work with that type of situation? So people with non-convulsive seizures are often obtunded or comatose. They often have clinical signs that either just aren't there, no matter how hard you look, or that are subtle. So some subtle findings that are commonly reported include subtle myoclonic limb movement, and those are often focal, not necessarily generalized. If they're generalized, they're often synchronous. And then face or eye movements also can be seen, which is really difficult because all of you know probably better than me that clonic movement of the jaw can be very difficult to differentiate from a patient who's chewing on their endotracheal tube. About 90% of the patients with non-convulsive seizures can only have that diagnosed on EEG. So we also recognize that this is a difficult conundrum in the community when transporting a patient is costly and not necessarily the safest option for them. Next slide, please. So what are some signs to look for? Reported in the literature are semiology of many different kinds that can go with non-convulsive seizures or non-convulsive status. I won't go through this whole chart, but essentially you can have either negative symptoms, meaning a lack of something, so lethargy, confusion, coma, amnesia, and anorexia. You could also have positive symptoms, so agitation and aggression that's out of the ordinary, delirium, delusions, blinking, crying, many other types of things. So this just kind of highlights how difficult it is to parse through these signs when you don't have EEG to help you out. Next. Excuse me. So that leads to the question of what are some predictors or what can tell you historically that this patient is at higher risk of having non-convulsive seizures or status epilepticus. And those patients are patients who've had a recent convulsive seizure. So they either came into hospital with a seizure or they've had one in hospital before their decline. If they've had recent subtle movements, that could be ictal. If they've had a history of epilepsy, so any history of seizures and epilepsy in the past really raises a red flag for this population. And also history of anti-seizure medication use. And where this is most difficult to interpret would be patients who are on anti-seizure medications for either management of neuropathic pain or for psychiatric reasons. So in the past, they may not have ever had seizures, but they're on these meds. And if they're stopped abruptly, it's harder to know what situation you're in for them. Next slide. Other entities that can also be seen and look similar or be misinterpreted as seizures are things like movement seen with syncope, shivering or tremulousness, rigors, posturing. Also, if somebody has brainstem injury, can look a lot like seizure. And then dystonic movement disorders also can look like seizure. And psychogenic non-epileptic events are often less common in critical care because of the degree of sedation or obtundation of patients. And oftentimes, they're not able to manifest non-epileptic spells that are purely psychogenic, but that's not completely unheard of. We certainly do see that in critical care. Next. So I wanted to take a little minute in the context of not having an EEG in your institution to talk about a benzodiazepine trial. So I'm sure you've heard of benzodiazepine trials and probably done them before, but for patients with status epilepticus or a concern for status epilepticus or an EEG that's ambiguous, a benzodiazepine trial is a really good way to see if you can get improvement with the patient. So a patient with to get a positive benzodiazepine trial and to tell you that this was status or this was an ictal problem for the patient, you need to have a couple of things that all line up together. So first of all, in theory, the patient would have rhythmic or periodic discharges on their EEG. And if you don't, some of the terminology in this slide is a little bit older and outdated, but I still think it's a good description, so that's why I have it up there. But essentially, if you don't have EEG, you can still do a benzodiazepine trial, you just can't have all the components of a positive trial. So in theory, you have the patient on EEG, but outside of that, you should have monitoring for other vital signs, so your pulse oximetry, blood pressure, ECG, which you usually have in critical care. And then there's two ways to do the benzodiazepine trial, and you can call it anti-seizure medication trial instead of benzo if you choose. But you can use a reasonable dose of benzodiazepine to see if you can stop the abnormal movement or the abnormal sign that you're concerned is seizure. If it stops it, that's good, but in and of itself, that doesn't tell you it's a positive benzodiazepine trial, because you guys all know that benzodiazepines will stop a lot of things just because they cause sedation. So the other aspect or piece of that you want is for the patient to actually improve clinically. So if a patient was in non-convulsive status where they're awake and they're protecting their airway, they're not intubated, and you were to give them 2 milligrams of Ativan, you would expect that they might be more sleepy, but they should become better oriented and be able to answer your questions and things. So that would be something that pushes you towards a positive benzodiazepine trial. That happens pretty quickly. If you do it with a benzodiazepine, you should have an almost immediate improvement or within a couple of minutes. The slower way to do it, but less aggressive, for example, a patient who's not yet intubated, would be to do an anti-seizure medication trial. And so with those patients, you would load with an anti-seizure medication such as levetiracetam or phenytoin. And you would gauge whether or not there's a clinical improvement with that patient over the course of a couple of hours after you've given them the anti-seizure medication load. Now, ideally, you would have EEG, but we know that's not possible for all patients. The other component of a positive trial is that the benzodiazepine or anti-seizure medication administration results in actual improvement in the EEG and resolution or improvement of the ictal pattern. Next slide, Derek. Thank you. Okay, so when a seizure is suspected, this is kind of your common approach to it, but essentially you want your labs to rule out metabolic causes. Common causes for seizure that are provoked and can be focal or generalized in onset would be hyper and hypoglycemia. It's quite common with sugar disturbances to have focal onset seizures, which is a little bit disconcerting and always makes you think twice. If there's a leukocytosis or fever, obviously a lumbar puncture is indicated too. This is a key point that I think we see variably across the board. Sometimes it's implemented, sometimes not. So I'll just kind of go through it. But if a patient has known epilepsy and they've come in with seizures or status, oftentimes the medications they're taking at home are not available through the intravenous route. And it's not uncommon that we'll see those medications are held and they're given intravenous anti-seizure medication instead. But it's actually super important that we don't hold those anti-seizure medications. We give them through the NG tube. And if any additional medications are required, they can be given through the IV. And the main reason for that is oftentimes one of the triggers for a patient with epilepsy to come into hospital with status is actually that they've missed doses or they haven't absorbed them well for some reason because they had a virus or something like that. And so restoring their home medications is often adequate to get them controlled again. Next. Okay, so I quite like this slide because it goes through the timelines a little bit, but as everybody knows, time is brain if you're having a stroke, but not everybody realizes that time is brain equally so when you're having status or seizures. And so from the point of view of status epilepticus, you want to treat as quickly as you can. So that's where the algorithms come from, and our current recommendations suggest that we need to treat as quickly as possible. And a seizure is considered prolonged and warrants aggressive therapy if it's over 5 minutes. And then even more so if it's at 30 minutes or more, because at that point in time, the seizures are less responsive to medication. And the sooner you're able to gain control of seizures over that arrow going from top to bottom, the better your outcomes will be. Next slide. So these are the standard algorithms that you'll see in a lot of guidelines and things. And I wanted to go through a few updates just because not all the algorithms have been recently updated. So most of you would be very comfortable with your emergency management and stabilization of the patient. You make sure that you take care of their ABCs, you monitor their vitals, and you use a first-line benzodiazepine, which would be the second level of this chart. What's important to note from a benzodiazepine perspective is that it's just basically whichever benzo you have most readily available. So we know that IM midazolam is pretty well equal to IV lorazepam and IV diazepam. So which one you use doesn't matter. But the other piece of that is that you use an adequate dose. The next box down, so the third level, is that using an anti-seizure medication IV is required if the seizures are continuing. And our most recent data, which I'll go through in a few minutes, is that Fosphenytoin, or in Canada, what we have is phenytoin, valproic acid, and levetiracetam are all considered equal in randomized controlled trials. So it doesn't matter which one you choose. You should choose the one you can get into the IV the fastest. And then on the last level is if the patient becomes more refractory and they require anesthetic medications, and there's really not a lot of data to tell you what's best. Next, please. Okay, so for first-line anti-seizure medications, the ESET trial actually looked into this in a fair amount of detail. I don't expect you to look at all of this, but I think the really important piece is the guideline recommended doses per administration, and the dose based on the patient size. So lorazepam is probably the most common benzodiazepine that we would use first off if the patient's in the emergency room or on the floor. And midazolam is often used more if they're already in critical care, just based on what's easily available. If you look at the actual guideline recommended doses for lorazepam, it's 0.1 milligrams per kilogram. So if you take somebody who's 50 to 70 kilograms, they should be getting 4 milligrams per dose as opposed to the 2 milligrams, because we often shy away from our maximum dosing so that we don't need to intubate a patient, but that's also part of the reason why we don't end up stopping seizures. And so earlier seizure kind of cessation goes along with higher first doses of benzodiazepine. So your first dose for an adult over 32 kilos should be 4 milligrams. Similarly, for a patient with midazolam, your first dose for somebody over 32 kilos, which is most adults, should be the 10 milligrams. Next, please. The ESET trial looked at this actually in detail and showed that greater than 75% of first doses of benzodiazepine were lower than recommended. So just to give you some background, if you're not familiar with this trial, it was done relatively recently, published in 2021. And it looked at 3 different anti-seizure medications as first line to see if there was any superiority. So on average, it took 27 minutes for patients coming into the emergency room to receive their first benzodiazepine dose, and then an extra 6 minutes to receive any cumulative or adequate doses. And so the red bars actually represent patients who did not meet guidelines, and the blue bars represented patients who did meet guidelines. This study was done in the US. So you can see even in recent years, just pre-pandemic, many patients were not actually meeting guidelines for the doses of benzodiazepines they were being administered. Next slide. So in that trial, it's in the last column on the right. They compared fosphenytoin to levetiracetam to valproic acid in patients 2 to 94 years of age. It was an RCT that was blinded and multi-centered, and they had 400 patients. And what they were able to show as their main outcome is that all 3 of these medications are absolutely equal for management of convulsive status. So you should choose whichever one's closest, like I said earlier. To back up their data, 2 other studies were going on at about the same time. One was Eclipse and one was Concept, and both of these were in pediatric populations. So that's why they didn't include valproic acid, because oftentimes it's not your first go-to in children. So they compared phenytoin versus levetiracetam in both studies, and had a slightly smaller number of patients, but both were RCTs, and they also showed that levetiracetam and phenytoin are equal for stopping seizures. So really, you should choose whichever one is closest and fastest. The reason that valproic acid's not used in pediatric populations as much and as liberally in those other trials is because metabolic disorders are a more common cause of seizures and status epilepticus in children, especially under the age of 2. And if you give valproic acid to somebody with an unknown or unidentified metabolic disorder, be it mitochondrial or a urea cycle disorder, then it can cause fatal hyperammonemia that's associated with herniation. So interestingly, that's one of the things they did look for in the ESET trial, and they didn't have any instances of unexpected death associated with valproic acid in pediatrics. Next slide. Okay, so this slide is honestly just a quick reference off the top of my head kind of thought. I think it's helpful to know what your options are from the point of view of intravenous anti-seizure medications and what's out there. You may not have all of these available at your hospital, but if if some of them confer advantages that it would be nice to have, then it's good to know they're available so you can advocate for them too. Essentially, phenytoin, valproic acid, and levetiracetam are fairly easily available across many institutions, although many don't carry valproic acid. It needs a special access to have it in-house. So most of you will have phenytoin and levetiracetam easily available, then lacosamide and brivaracetam, I'm not certain, depending on your hospital. Essentially, they all have relatively standard loading doses. Most of them are milligram per kilogram, unless you look at lacosamide and brivaracetam, and there the studies are relatively lacking. So what we do have is just a dose range for your loading dose. The worst side effects I have listed here. With phenytoin, you need to run it in slowly, as you all know, and you need to use a filter because it can precipitate out. But if it's run in too quickly and goes interstitial, you can have purple glove syndrome with sloughing of the skin. And there's hypotension and bradycardia associated, so you just have to watch those. Valproic acid, the big thing to watch for is hyperammonemia. So if you're using it IV, you should be monitoring ammonia subsequently for several days. The hyperammonemia can be related to urea cycle disorders, but it also can be seen in people who might have some nutritional deficiencies, such as carnitine. So it's good to monitor that because you don't want to cause encephalopathy and not realize it. And then your worst side effects with levetiracetam, or sometimes it can cause profound agitation in critically ill patients. DRESS syndrome can be seen with it and many of the other anti-seizure meds. Lacosamide's worst problem is PR prolongation. Usually it's not a problem, but I have had a patient go into bigeminy after administering it, so it is something to watch out for. Dr. Debicki, I'm going to ask you to unmute. Have you run into the worst side effect with brivaracetam? I haven't had any.
Used it enough really
Yeah.
At least I haven't seen it, and I haven't really heard too much of it.
Yeah, I've noticed. I mean, my anecdotal is that loading doses with brivaracetam have been relatively benign, but I'm sure I just haven't used it enough either. The other thing to note, I don't expect you to memorize the table, but levetiracetam is kidney clearance, and everybody assumes because brivaracetam is closely related to levetiracetam that it's also cleared by the kidney, and that is not correct. It's cleared by the liver. So sometimes it's an advantage, and other times it's not an advantage. So just need to keep that in mind. Because of those worst side effects, there's certain situations when you don't want to use different anti-seizure medications. So we tend to avoid levetiracetam if there's kidney failure and use any of the others. If there's cardiac abnormalities, including atrial fibrillation, then lacosamide should be avoided. Giving a medication like brivaracetam in hospital is great because we pay for all the medications in hospital, but as soon as the patient leaves, they need to be able to pay out of pocket for it, and brivaracetam is prohibitively expensive still. So, you need to consider that for your patient too. And then phenytoin and valproic acid have similar kinds of contraindications, basically liver dysfunction or underlying mitochondrial or metabolic disorder. And then the most on the may cause line here, there's lots of other things. This is not comprehensive, but certainly the common things I see with phenytoin and valproic acid would be rash or hyperammonemia that are dose limiting. Levetiracetam, it's not uncommon. It will cause thrombocytopenia that might be limiting and you have to change off of it. Lacosamide, I've definitely seen the cardiac conduction changes, and then brivaracetam is classically noted to cause some neutropenia, but I, again, haven't used it enough to see that yet. Next slide. Okay, so I mentioned before that time is brain, but there's actually data to support this. Can you hit the next key? There we go. So there's data to show that if you can achieve seizure control within 1 to 2 hours, it's actually a determinant of outcome from a morbidity and mortality point of view, especially cognitive. Delaying benzodiazepines by more than 10 minutes is actually independently associated with death, the need for continuous infusions, so going to ICU, longer duration of convulsions, and hypotension. Next. These are some of the data that back that up, so I won't go through all of it. Some of the faults of the data, if you look in the third column, is the duration varies based on which study you look at, so they classify short and long periods of seizures very differently. The one that would be a big difference is the one at 10 hours there. But essentially, to me, what this data is driving home is that the sooner you treat a seizure, the better off the patient will be, and the less their morbidity and mortality will be, the less chance they'll have for poor outcome. So aggressive treatment is really important. Next. When we talk about status epilepticus specifically, It happens because the brain has a failure of mechanisms that are meant to terminate seizures, like their inhibitory neurotransmitters, and there's also initiation of mechanisms that lead to prolonged seizures, like inflammation. And as you guys know, when you move through status, the longer you are in status, the less chance you have of the brain responding to your anti-seizure medications. Next key. So I alluded to before, but essentially with convulsive seizures, a prolonged seizure is anything greater than 5 minutes, and an abnormally prolonged seizure is at 30 minutes. And that's because at 30 minutes, you then have long-term consequences and changes in the brain. Next. So some of the changes are based on receptor systems, and this is why we try to use rational polytherapy also. Can you hit the next button? This is sort of half animated, so your GABA receptors get internalized, and over the course of 30 minutes, they're no longer on the postsynaptic neurons. So that's why they don't respond to the benzodiazepine. Next. You also have changes in NMDA receptor expression, and so there's increased excitation, which is not really what you want. Next. Adenosine receptors change on the presynaptic neurons. Next. You also have changes in the GABA receptors on the presynaptic neurons, which are a different type of GABA receptor. Next. And your AMPA receptors also change, and that leads to accumulation of calcium within the neurons, which can lead to cell death. Next. And your drug transporter proteins get increased expression over time, and so you're pouring in anti-seizure medication, and the neurons, unfortunately, are working really hard to eject that and not use the medication you're giving. So the faster you can give it before those transporter proteins are expressed in the membrane is the better. Next. Okay, so the other things that happen that support ongoing seizures and status is breakdown of the blood-brain barrier. There's increasing data to tell us that there's clear inflammation going on. There's microglial activation. We get persistent, basically, synchronization of the neurons, and they can no longer transition from ictal to post-ictal. Next. So physiologically, or what worries us at the bedside is that this can lead to hypotension, hypoxia, and acidosis, so difficulty systemically for the patient. And then prolonged seizures actually injure the hippocampus, specifically in the CA1 and CA3 areas. You get intracellular calcium accumulation, like I alluded to, which causes mitochondrial damage, and then that leads to damage in DNA and things, and reactive oxygen species. Next. So when we do classify status, or we're communicating about it, we tend to classify it by semiology and etiology, as well as any EEG correlates we have for it and the age of the patient, because all of these factors, when you're chatting on the phone with someone for advice or communicating about the patient, really do influence what type of advice or decision-making is provided for that patient. Next. I just have a few examples of what things look like, recognizing that not everyone has EEG. I can't, being an EEGer, can't not show it. So this is a patient on subhairline EEG with the EEG 1, 2, 3, and 4 in the bottom 4 rows. And this patient has a convulsive seizure, so there is some spike and wave in here, but it's also quite contaminated by movement. Next. I don't have a pointer here, but this patient is in focal status, and you can see on the MRI in the left hemisphere, there's definitely abnormality. Thank you, Dr. Debicki's pointing at the spike and wave that's abnormal happening in the left hemisphere there. So the top row and the third row of tracings. Next. And this is an example of a patient with focal status. You can see the CT on the top right is essentially normal, but there's clearly focal change that's in the right frontal region, right there, with rhythmic changes that are kind of progressing throughout the EEG. Next. Okay, so non-convulsive status. Next, thanks. So this is an example here with a patient who has no clear physical manifestations, but Dr. Debicki's pointing out there the spike and wave that is marching through the EEG. And what Dr. Young always used to teach, which I think is very clear on this one, is that if your EEG looks a little bit like a STEMI, then you're in big trouble. Next. Okay, so electrographic seizures, you need an EEG to diagnose, but essentially this is an electrographic change that's happening either for greater than 10 continuous minutes or for greater than 20% of any 60-minute period of recording. And the reason that this is now defined as electrographic seizures is because we have data to tell us that if people are having these changes on their EEG for a longer period of time than what's on this slide, then it leads to permanent neural damage. Next. So overall, just to kind of review things together, when the brain fails to terminate seizures and you have inflammation or other situations that set you up to prolong the seizures, you get status epilepticus. The reasons that you get receptor changes are why we try to use polytherapy. So we're trying to target the different types of receptor systems that are changing. And if the seizures are prolonged, then you do get a lot of pathophysiological changes that persist and cause damage. Next. Handing it over to you.
Great, thank you. So now we'll just kind of look at maybe managing status epilepticus in community hospitals or rural hospitals and looking at it from a little bit more of a systems point of view. And just to open the discussion, likely remembering the kind of the idea that the quicker that we can start to treat patients and stop seizures, the less likely we're going to have more prolonged seizures in status epilepticus, or if they are in status epilepticus, to prevent having refractory or super refractory status epilepticus. So this is just like the timeline, not only in the hospital setting, but also outside of the hospital. It's education to the public to allow family members and caregivers to recognize that a patient might be having prolonged seizures, timing for ambulance systems to be able to arrive to the location where they are. And in some rural settings, then that might be really challenging and might be delayed as well. The time for the, and so it might be that, and the time to then reach the emergency department. So it might be trying to give the EMS team tools to be able to manage things out in the field more effectively. From the time to reaching the emergency department to time of diagnosis, as emergency room physicians are becoming more and more educated, then this time is really decreased significantly, and including time to first line treatment through discussions about benzodiazepine use and first and second line anti-seizure medication use, as Dr. Gofton had mentioned, time to second line treatment as well. This might be understanding what medication, as Dr. Gofton said, is available to you in the emergency department or available to you in the ICU. So for example, I think that phenytoin has always been used because it's readily available in the emergency department, and in kind of at the bedside in the ICUs, it's very easy to put into a mini bag and hang and run as quickly as it can be. And so it was always available, and therefore it's very easy to use, and probably the one that was used the most often. There was some literature that came out a number of years ago now showing that levetiracetam can actually be infused quite quickly, and in some cases even be IV pushed. We took that literature to our pharmacy here at LHSC, and we were able to get at the pharmacy to then stock levetiracetam at, in the medication rooms on our neurology ward, in the emergency department, in the ICU, and teaching the nurses how to put it into mini bags and hang it and be able to get it into the patient really quickly, infuse it over a short period of time. So that was a big change for us, I think, because before we used to order levetiracetam in the emergency department as the neurology team, and it would take 45 minutes to get from pharmacy. So that's not useful in this context where time is brain. So working with your pharmacies to see what is available, what does the literature support as we can get things into patients really quickly. If necessary, time to intubation, again, that's probably either in the emergency department or in the ICU, and time to IV anesthetic treatment. And then also time to continuous EEG. We'll talk a little bit about that in terms of what that might mean. So in some places where rural medicine is very challenging, such as in India, they did a lot of education around this and started a treatment strategy for their rural hospitals, an education kind of program, and which really is exactly what Dr. Gofton had has taken you through in terms of initial and second line treatments. And so just kind of, again, reemphasizing that this is important to be able to teach to hospitals that are not necessarily academic centers, but also who are going to be seeing these patients directly in their emergency departments. In Canada, we have some unique situations, and Marcus Ng is an epileptologist, one of our colleagues in Winnipeg, and he's written about the challenges of treating some of his patients in Nunavut, which then Winnipeg would be their referral site. So it's the challenge of being able to remotely kind of determine whether patients need to be airlifted upwards of 1,500 to 2,000 kilometers to the referral site in Winnipeg, and how to manage that remotely, and then what type of services are available in the referral site in Winnipeg for them. He did go through this a little bit with taking a look at a registry of a number of patients who were airborne evacuations to Winnipeg. Some of them at the top of this slide here, the majority of them met the criteria for clinical criteria for status epilepticus, some because of prolonged seizures and some because of recurrent seizures without complete recovery. And some of them were generalized or focal, again, generalized or focal for this group. And when they were able to be brought down to Winnipeg, the time delay to be able to get an EEG, as you can see, are multiple days often. But when they actually did the EEG, they only found that one patient was still in status epilepticus based on EEG criteria. This really emphasizes how important it is to treat the status epilepticus clinically right up front, and making sure that you're treating the clinical syndrome as well. And some of the patients with clinical recurrence also had status epilepticus, but a lot of them had either intermittent epileptiform discharges or just slowing on the EEG by the time that they got to Winnipeg after initial treatment. Some patients didn't necessarily fulfill the criteria, but were concerning enough to bring down. And again, when EEG was applied, then some of them then met criteria for status epilepticus based on the epileptiform activity of the EEG, whereas others just on the EEG had focal or diffuse slowing, or others just kind of looked unremarkable by the time that they got down to Winnipeg. So I thought it was kind of interesting looking at this very challenging partnership between the Northern Territories as well as Winnipeg. From the NeuroCritical Care Society has what we call the Emergency Neurological, the ENLS, I guess. It's kind of like very similar to an education program to teach how to manage neurological emergencies. And they always kind of describe for certain conditions, what is it that the person on the other end of the phone, if you're calling to make a referral, what would they find really relevant? And this really highlights that understanding and being able to communicate what the clinical presentation is, what the duration of the status epilepticus has been, all of the relevant past medical history as you would normally do, but also being able to provide a neurologic exam and whatever imaging that you've had available to you as well. So really, and also knowing what medications had been used, what has been given so far, what's worked, what hasn't worked, and those types of things. So if you are making a referral to a different center, then just really having all of these in mind when you're going to be able to provide that stories as you usually would for any other type of condition as well. This is a little bit of a map based on a task force that was created about a decade now, where they've really consolidated and recognized certain centers in Ontario as being epilepsy centers. Some are called district epilepsy centers, which have the ability to monitor patients with EEG in the terms of an epilepsy monitoring unit, not necessarily continuous EEG monitoring in a critical care center or setting, but these are the epilepsy units in Ontario. The ones that are the regional epilepsy surgery centers of excellence, such as at LHSC and UHN, also have surgical capabilities. So I just wanted to provide a map of saying, like, where are the big epilepsy centers in Ontario? And I wanted to contrast that, or show that it's relatively similar to this is from the Southwestern Ontario Stroke Network, highlighting all of the stroke centers and the different regional and district stroke centers that are available in Ontario, and just kind of closing in on a little bit more Southwestern Ontario, not all the way down to Windsor, but just showing kind of this area where we have London as being a hub that is able to provide interventional capabilities in the stroke network, and then having other centers that are TNK centers or TPA centers, and then other hospitals that would then be referral hospitals as well. So, I think that it's an interesting kind of network that's been really organized and works quite well. And, hopefully that we see someday a time where we could consider developing something similar for status epilepticus, which is also being recognized, as Dr. Gofton mentioned, a very severe type of presentation where, again, time is brain. Some centers have gone so far as to make kind of seizure code teams where if patients come into hospital, then in the emergency department, they would call a code seizure or code status type of thing, just like they would with a code stroke. And just recognizing how important it is to diagnose and treat as quickly as possible. So, it would be a vision, a great vision, to say that we could have a similar district or central places where either patients could be managed with some more expertise, or having the ability to do remote help with either remote EEGs or remote consultation services with experts at a more central site. So hopefully we can get to a point where we could consider something like that at some point in time. But at this point, I think we'd just like to open it up a little bit more to questions and discussions if anyone has that, and hopefully we've been able to provide some good input for you, or things to think about for these patients that present to you.
Thank you so much, guys. That was an excellent talk, and I'll leave it. I'll monitor the chat, or if anyone wants to speak up, please go ahead. So yeah, go ahead, Tom.
Hey, Derek, it's Tom Hafner in Stratford. Thanks for the wonderful talk, and thank you, Dr. Gofton. That was really useful. To sort of follow up on your point, I think many of us would be happy to manage patients locally if we had sort of more ready access to remote EEG and supports. Is there actually anything in the pipeline, looking at it, where we could apply the, hairline EEG, and you guys can look at it sort of remotely, and we can kind of come up with a plan rather than, transferring?
Yeah, that's a great question, and it really is something that we've talked a lot about. I think that we talk a lot about that with some of other hospitals as well. I really hope that we can get there. I think part of the I think there was a couple of things that are starting to open up that might make it easier for us to be able to think about actually developing a network like that. So first would be the idea that we can probably do, it's more easily acceptable to do kind of tele consultations or remote consultations. I think that's a bit easier to do rather than needing to go there and see the patient in person. And a lot of these patients, I think, if we had access to EMRs and some of the information and imaging, and like you said, an EEG, then we probably could help co-manage to a point where we felt like, okay, now it's time that we need to bring patients down. The other thing is that technology is improving in terms of being able to think about getting more caps or nets that are easily applied by local providers. And there is some technology. I was just at a NeuroCritical Care Society meeting and looking at some of the vendors for this, and there is some technology where it's kind of wireless, and information goes up to the cloud, and then people can kind of log in to see. Of course, we have to get Health Canada approval. I think that's probably the biggest kind of roadblock right now for some of these systems that are developed in other places, like in the States, but certainly not insurmountable. And and just kind of figuring out a good network of doing that. Because before, I think one of the troubles was, would you need databases? How do you have servers? Where are the servers going to be housed? But I think if you start to use some cloud technology, that makes it a lot easier to be able to think about that. So I'm really open to having these discussions and trying to troubleshoot and seeing if there's actually a suitable kind of vendor that would have a product that everyone would be happy using. Camille, you wanted to add?
Well, I was just going to add to that. I absolutely. The one limitation is the simplified EEG montages are a good screen, but I don't think they're adequate to prevent transferring a patient where we have questions. So still having the full scalp coverage is pretty essential. But as you were saying, some of the newer technologies will have that, and it would be great to move something forward, because you think a remote network should be easily possible in the current day and age of technology.
Yeah, I should have kind of said that. There's literature, and you might read about this in the critical care literature about something like there are limited montages. We use a type of limited montage here at LHSC, but there are some that are being promoted in the US. One's called Cerebell, which is a very specific type of, and there's similar products, I think, elsewhere. But again, that's more of a limited montage. I'd be thinking more of something that might have a cap or a net where you could apply a full EEG, but not needing necessarily the EEG technologist to do all the measurements for that. So make it simplified from an application perspective.
Thank you very much for that answer. I know Brenda Morgan has a question in the chat, but there's been an anonymous question asked along the same lines of, people I think are very interested in setting up regional seizure centers, especially in Southwestern Ontario. What are the barriers right now in implementing it, or what would the first step be if we want to go along that pathway?
Yeah, no, I think it's a great idea. I've had these conversations with different people in different levels of the hospital. I think it's probably, I would think that at first, in principle, I think we would want to have a discussion with the different centers to say what's capable, what's possible in terms of getting a technology that would work, and to be able to kind of set up a network of remote consultation that would work. It might mean to do a pilot project with one particular center or one or two centers to see. But again, we need to have the technology in place. But I think it also needs to happen at a higher level from hospital to hospital, because the questions are going to be who's paying for the technology, and who's, providing that, who's going to do the upkeep of that. So, I think in principle, it makes a lot of sense. I think when we think about it practically, then there's lots of levels of that would need to be in place. However, I do think that the backbone of having the stroke network would be a very good place to start, because already those types of conversations happened, and there's technology such as teleconferencing or video conferencing already that might exist in certain hospitals. So that means that, I'm not sure if it would mean that we would have to be able to access electronic patient records, and which in local hospitals around here we already do have access to. Yeah, so I think there's many things that are in place, but unfortunately I probably don't understand the administrative side of things and the hospital to hospital agreements that might need to happen, or things such as privileges and those types of issues. I'm not quite sure what all of those would be needed in order to set up a network like that. But again, stroke might be a good exemplar to follow.
Yeah, the other barrier is that the devices that do not require a technologist most of them don't have Health Canada approval, and we can't use devices without Health Canada approval directly on patients, just for research, and not for research that includes patients.
Thank you. So Brenda Morgan writes in the chat here, thank you. Are the pregnancy drug contraindications across all trimesters, and is the contraindication teratogenicity or something else?
Fair question. So phenytoin and valproic acid are basically completely contraindicated in pregnancy, but the main reason is for teratogenicity, which is more of a first trimester issue. In the past, they have been used in late kind of second and third trimester. But I think that would be frowned upon now if you have access to either lacosamide or levetiracetam. Levetiracetam is one of the safest anti-seizure medications in pregnancy, and we have good data to back that up through the whole course of pregnancy. So I think you just need to avoid phenytoin and valproic acid in pregnancy altogether, if possible. So I think, I mean, in theory, it would be amazing if each hospital had at least phenytoin and levetiracetam as their available intravenous anti-seizure medications, but I know that's not universal across the board.
I'll give another minute if anyone else has a question.
Hey, Anton, it's Mike, just one of the previous trainees from Western. Thanks so much, guys, for the talk. I had a question, if possible. I know you just have short minutes here, but sometimes I find in ICUs we're approached after a patient has a tonic-clonic seizure and is not returning to baseline after some arbitrary period of time, whether that is ongoing seizure or otherwise. I don't know if you guys can speak to any kind of general comments regarding expected time to resolution, and I presume it's fairly variable, or even rates for patients to have like a tonic-clonic seizure thereafter to be maintained in like a non-convulsive status kind of picture. That would be very much appreciated. Thanks.
Do you want to pull up your slide, Dr. Debicki or Derek?
Sure. Yeah.
The slide with the percentages, because that particular scenario is the first line on that slide. Just while you're pulling that up, I would say it's very difficult, but your highest risk patient for status is the patient who previously had a bilateral tonic-clonic seizure of some kind. That patient is at highest risk of having an abnormal EEG and being in non-convulsive status. They're the 48%. There's not really a well-established time window. You can chime in here, Dr. Debicki. But I think, if they were administered a large dose of benzo, then that obviously clouds the picture and is more difficult to interpret. But after that, I wouldn't expect any of the other anti-seizure medications you give IV to cause a patient to remain obtunded. So, I mean, if the benzo is not clearing in a short-ish period of time, then that you can at least wake the patient up some and have them be sensical, then I think you need to be worried they're in status.
Yeah, I think that's the biggest challenge, and we've certainly had consultations regarding that as well. And it's hard to, it's hard to give advice even over the phone. But I think that's the general kind of idea is that I think, given any other patient in that circumstance, given the medications that were given, are they recovering to the rate that you would expect them to recover? So the idea is that if you have, someone who's having a lot of seizures, even if you give big doses of medications, you might get some sedating side effects, but it should stop seizures, and that should help them with their cognition and interaction. I think that if you had someone who was from Emerge and was intubated on propofol and you wean propofol, then if they're not in status anymore, then they should kind of wake up the same time that you would any other patient that you have on propofol and intubated. And if that's not the case, then you might go down the algorithm of what Dr. Gofton mentioned of doing either a benzo challenge or doing another anti-seizure medication challenge to see if they would wake up with that. Either way, you'd be more covered by doing that to see A, if they're waking up, and B, if they are in non-convulsive status, then you're still giving them extra medications to do that. So, I think that's that hopefully gives some guidance. I have talked to a few physicians on the phone over time where they've been worried to give too much benzodiazepines because they were worried about losing a neurologic exam or like intubating a patient needing sedation and losing a neurologic exam. I think in this context, just like Dr. Gofton highlighted, you need to give them adequate doses of benzodiazepines. I spoke with, or one of the people who were on the guidelines that said the maximum dosing of benzos of 4 milligrams with the lorazepam. They actually said that they were, in retrospect, they kind of wish they didn't put that maximum in there because they recognize that we're still probably underdosing people. So, maybe a maximum would be to the point where, you're giving benzodiazepines until you need to sedate them and perhaps intubate them if they're still having ongoing seizures. So, yeah, a challenging situation, no doubt.
That's great. I want to say thank you to both Dr. Gofton and Dr. Debicki for another great SWOCCS session. Thank you everyone for joining. I know we're out of time here, so if you do have any further questions or concerns, our emails are there, as well as the Google form that I've put into the chat. It should be around the top. Our next lecture is going to be by Dr. Leah Nicoletti later in November, talking about her experiences at St. Thomas Hospital and sort of the transition she had from fellowship at an academic center and now practicing as a community ICU physician. And so we're very excited about that. Thank you very much, guys.
It was a pleasure to be here. Thank you so much for having us.